trained orthopedic surgeon with Tri-State Musculoskeletal Centers and sees patients in the Cranberry, Mars, and North Hills offices. He's a member of the Hip and Knee Reconstruction team. I might need to talk to you about my knee here soon. Dr. Abraham trained at the University of Pittsburgh School of Medicine and the Hershey Medical School at Penn State. He also completed a total joint replacement fellowship at Peachtree Orthopedic Clinic in Emory University. He was the recipient of a 2-year research grant to study total knee replacement and has since written several articles on total knee and hip replacement procedures. In 1996, Dr. Abraham joined the Pittsburgh-based Tri Rivers, where his practice focuses on total joint replacement surgery and general orthopedics. Board certified by the American Board of Orthopedic Surgery, Dr. Abraham is a member of the American Academy of Orthopedic Surgeons, the Pennsylvania Orthopedic Society, and the Pennsylvania Medical Society, and the Allegheny County Medical Society. So please join me in welcoming Dr. Abraham. You decided? Yeah. Okay.
What happens if you cross the blue line? She said
you're in front of the slides.
Oh, okay.
Then
Well,
you're all highlighted.
I assume you can hear me. Good. I opted for the handheld microphone. I wasn't sure I wanted to have the whatever it was wrapped around my head. Thank you for taking time out of your morning. This is perhaps the first time I've ever arrived anywhere on time, and they told me to make sure I got here at 8:30, even though my talk wasn't until 9, figuring that I'm customarily late, but here I am. When I was asked to come and talk, you're always trying to figure out how do you present anything that that has the word surgery attached to it, and sort of present a sort of a balanced approach to what we're dealing with. We've already heard that arthritis is a significant cause of problems for a lot of individuals, from everywhere from children all the way up to adults and seniors. And as I've gotten older, I'm now realizing that I had to buy a ticket for recycling, and I now qualify as a senior. So it's pretty much, it's inescapable. When I was younger, I would tell people that arthritis is sort of the burden of having lived a healthy life and been around long enough to have the aches and pains that everybody refers to as arthritis. And in general, that's mostly what we treat. If you look statistically, there are a lot of different types of arthritis. You can run down this long list of diagnoses, but in large part, osteoarthritis is probably the most common type of arthritis that we're likely to run into. There's a secondary category of what often referred to as inflammatory arthritis, where there are lots of different other, rheumatoid and other things that we've been hearing about. But in general, if you lump them all together, what they do is affect our mobility and affect us to live what we would consider to be the life that we want to do. Most of us want to be able to get up and around. We want to be active. We want to be able to go to the store and live independently is sort of what we hear as everybody talks about being older. But now as I've gotten older, you realize you want to do what you want to do. I mean, you want to be up and around, and you don't want to have the aches and pains of your joints getting in the way. Yet it does for a large percentage of the population. Not only does it impact our abilities to get around and do the things we like to do, it impacts our abilities to make a living. If we're, to the point that we have to rely on other family members and friends, then it impacts, the rest of society in terms of taking people away from work. And so you can see there are a whole lot of numbers that are attached to both impact on individuals and impact to the economy. So suffice to say, it's something that is front and center for a lot of us as we move through our lives. Our job as an orthopedic surgeon, or what some people say is an orthopedic medicine physician, is to help our patients to manage their symptoms. And by and large, that comes from helping them not only through educating them, but walking them through the process of making decisions. When I was at one of our academy meetings a few years ago, I happened into a talk that was not on my list of things to go to, but the one that I had tended to go to was oversubscribed, so I had to pick another talk. And the title of the talk was "Give the Patients the Surgery They Want." And you're like, that's the strangest, sort of title for anything that anybody would talk about. The whole point of it was to realize if you don't engage your patients and understand what it is that they're expecting in terms of outcomes of the treatment, regardless of whether it's surgical or not, how can you possibly meet their expectations and how can you possibly expect to have a good outcome? So it all sort of begins way upstream with educating patients and, as I emphasized here, helping them to make good decisions for themselves. What I often say about orthopedics is that fortunately, we don't run into a lot of life-threatening problems. What we run into is lifestyle-threatening problems. And at the end of the day, a lot of that just has to do with what type of lifestyle we want. And the decisions that you make have to be sort of guided by somebody like us, but they have to help you to sort of meet your expectations. So when people come into the office, I've sort of over the years changed how I talk to people. You run into little speeches that you give along the way, and 20 years ago it was this speech, and 10 years ago it was a new speech, and now it's a different speech. But I've sort of when people came in to see me for hip and knee problems, I would often tell them that in my world the treatment for this is sort of divided up into 3 phases. And the first phase is everything that I call home remedies. Anything you can do pretty much on your own is generally okay. Bear in mind, we're treating, again, as I said, lifestyle issues. So we're not, sort of concerned that the person is sitting there with chest pain, shortness of breath, and need to go emergently to the emergency room. It's more a matter of, I want to be outside gardening. I want to take a walk. What can I do to keep me out there? And so, by and large, I tell patients that the first phase is everything you can do before you ever come in to see us. Most of the time, when people do arrive in our office, it's generally because they've decided whatever it was they tried initially didn't work quite as well as they wanted, and they're looking for more options along the way. And then if all else fails, the third part, which I try not to talk about when people come into the office for the first time, is what do you do when everything else isn't working? And surgery is obviously the last resort. So, in terms of looking at outcomes, and this, the first two the first two of the 4 items that are in this slide, if you think about it, again, expectations are such a huge part of life, and if you think of your as a parent and you're taking your children on a vacation and it's a long drive. And what better way to make the trip go poorly than to tell them that you're going to be there an hour, knowing in your heart you've never made this trip in less than an hour and 10 minutes, but it's about an hour. And somehow they have this sense that it's going to take them an hour to get there, only to be disappointed when it's an hour and 5 minutes and they're like, what's going on? And so life is all about setting expectations. And I think it's really important, for us as a physician, to not only engage our patients, but to help them to appreciate what it is that we have to offer them and what the likelihood that we're going to be successful in getting them to the point where they want to be. And it comes through, spending some time with people, educating them, and making sure that they're realistic about what they're trying to get, sort of get out of whatever treatment they're pursuing. And then, obviously that comes, if we jump to the last, we all are all part of a team. When patients have surgery and they come back and they're often saying, well, thank you very much. I'm so thrilled that you did a great job on me. And in orthopedics, I tell people we only get the ball rolling by and large. The patients do the heavy lifting in terms of recovering from hip or knee replacement. It doesn't happen without patients being, sort of involved, and more importantly, patients being invested in their decision that they've made the right choice for them. And it comes from truly getting, having that sense that we're all sort of part of the same team. And then through that, the term, empowered. I mean, most of us just want to feel like we're in control. I mean, we want to feel like we're part of the process. Nothing worse than feeling like everything that's done, is done for you, is done to you, as opposed to you being engaged in the decision-making process and feeling like I'm invested in what's going on next. And I think that's really important in terms of sort of optimizing outcomes. So you can't emphasize the idea of viewing all of us as a team, and that very much includes the patient, and it often includes their family and anybody else that might be a support member for them. So again, phase one, everything you can do without us. By and large, when you're treating, most arthritic conditions, and I will say, this is probably better for osteoarthritis than it would be for some of the inflammatory arthritis, but most of the time, the aches and pains, if you can figure out a way that keeps you happy, keeps you active, how can that possibly be bad? Health food supplements and Bengay and Icy Hot and over-the-counter medications. I often look at patients and I'm like, well, if the health food supplement really doesn't have a risk, and even though we might not be able to say there's a whole lot of science that says that it works or doesn't work, but if it doesn't have a risk, and even if the benefit's placebo, how can that possibly be bad? If you get up in the morning and you look around and you stretch and you look outside and it's like, this is a great day, how can that be bad? Even though nobody's going to tell you that that's an accepted treatment for arthritis. So by and large, the treatment for this is beginning with people making good common sense decisions and recognizing if they can make some minor concessions and work around some of the aches and pains, it really is not a bad way to approach most of arthritic problems that we're likely to encounter. So the phase one, what we this slide is sort of some examples. Like I mentioned, all the over-the-counter medications, modifying your activities when necessary, grabbing the cane that you thought was for your aunt or uncle, but now you're using it. But those are short-term measures that most of us don't enjoy, and there's nothing worse than telling patients they need a cane and they're like, I do not need a cane. I'm not that person. I mean, who wants to be? So a couple things that we do that I mentioned that have been sort of ingrained to me by the physical therapist and in training. A lot of patients have concerns that exercise is a problem. They're like, well, if I overuse it, then maybe I'm going to wear it out, sort of like the tires on your car. You spend more time on the road, eventually they wear out. But it's actually not true. People have looked at any number of studies over a long period of time at marathon runners and things of that nature, and asked the ultimate question: is there marathon runners any more likely to run into hip and knee arthritis requiring surgery than anybody else in the general population? And I have yet to see a convincing study that suggests anything to that effect. It's basically, yes, they can run into hip and knee arthritis just the same as any of us, but it's not because they were marathon runners. And you might ask yourself why, and some of it is sort of the physics of what goes on in terms of somebody that's athletic. One is most of us don't realize that in order for me to stand here, somehow stress is going from my body weight here through my lower extremities out to the floor, and somehow the floor is magically staying in place and supporting me. But your joints have to bear some of that stress, and if your muscles are in good shape, they can absorb, and some suggest 80 to 90% of the stress that would ordinarily have to go through the joint is absorbed through your muscles. So think of them as sort of the ultimate shock absorber. So keeping yourself in shape is really critical to joint preservation. In fact, a lot of people like to say it really is joint preserving part of care for patients with arthritis. Weight loss is truly simple physics. I mean, if you strap a 50-pound backpack onto your back every day and you say, how am I going to feel at the end of that day? You're not going to feel nearly as good as when you take it off. And so if you drop some of the weight, nobody's going to deny the fact that it just is less stressful to all of your joints. So those things are really, really important. And least of all, when you get back to combining those two, if you want to harp on that, is who doesn't feel better when they shed a few pounds, and who doesn't feel better when they're in better shape? And I think that most of us would acknowledge, although it's a bit of a process, and it is really something that you have to sort of make that emotional investment, it bears a lot of fruit when it's all said and done. So by the time people wander into our office, they're unfortunately to the point, well, I've tried that, and I really don't feel like any of it's working. What are you going to do for me next? And that's really where we come in. So part of this next phase of my career is what you heard was that I'm an orthopedic surgeon, true. What you heard was that I spent my entire career doing lots of orthopedic surgery and focused on certainly the last half of it doing primarily just hip and knee replacement. Not the last part, I guess, but at least the next phase is that I stopped operating. And so a few months ago, I made the decision that I am old enough that I've decided that I'm not going to operate anymore. And so what does an orthopedic surgeon do that doesn't operate? And so what we realized is, and I'm sure that everybody that's connected to the Arthritis Foundation realizes, is that the overwhelming majority of people that are treated with arthritis never have surgery. So most of the people don't need us dressed in our scrubs with a mask and gown and all that stuff on. What they need is us to begin the process and to help people again to understand what it is that their condition, what the diagnosis is, and what they can do to try and avoid ever coming back to see us. And so all of this is probably the biggest part of what we have to offer. I mean, in training, they used to emphasize the notion that orthopedic surgeons are truly the primary care physicians of the musculoskeletal system. And in truth, we sort of are. We take care of the bumps and bruises, the aches and pains. We're not nearly as smart as the rheumatologists because they're taking care of a lot of disease-related problems. We're just orthopods, and we do a lot of common sense sort of treatment for patients along the way. And so at least as my career continues to progress, I'm going to spend more of my time, doing the, I guess, educational side of things that I feel like I've generally done in the office. And then when that small percentage of patients actually require hip and knee replacement, we have two really well-trained, well-qualified, younger, smarter than me, better orthopedic surgeons to do it since I'm not. But thankfully, most people actually don't come to surgery. And so there's a whole lot to be done to keep people out of the operating room. And that's what we talked about and mentioned. When you come into the office, we're orthopedic surgeons. Not only do we talk to patients, we generally x-ray everything that hurts. I mean, it's sort of what we do because x-rays turn out to be really a good imaging study for looking for arthritis. It sounds, I could in 10 or 15 minutes explain to you how to look at a knee x-ray, and you'd be an expert like me, be able to look at knee x-rays and appreciate that this is normal or this is probably not so normal and maybe this person does have arthritis. But they're really effective at sort of getting a baseline on patients and trying to appreciate the extent of any, as people would say, damage to the joint or deterioration of the joint. So x-rays really have a vital role. MRIs are valuable. Interestingly enough, when I started my career, there weren't a lot of MRIs around, so you were very selective about who you ordered an MRI on. Now there's an MRI on every corner, and you can get lots of MRIs, provided you can get them scheduled. COVID did change that a bit. But at the end of the day, what's interesting for knee patients, and they've done these studies for hip patients, not for hip patients, it's easier to knees, shoulders, backs, is you do MRI scans on normal individuals. And it turns out that 30% of patients have rotator cuff pathology, 30% of patients have a meniscal tear, 30% of patients have disc herniations. And so the MRI is a powerful tool. What it doesn't do is tell us whether any of the findings on the MRI have anything to do with why the person's sitting in front of you. And those studies, again, were done on normal individuals with no aches or pains and no prior history. So the MRI is not all that valuable when we see patients in the office because it isn't going to tell us so much about what we want or tell us how to treat the patients. And the backside to that story is even more important, is that by virtue of that, what people have done now with lots of computing power is they dump a whole lot of information into the computer hopper, and out of it spits, oh, this is what you need to worry about, or this is what you don't need to worry about. People generally are concerned, if I have a meniscal tear, so-called cartilage tear, what's going to happen to me if I live with it or if I ignore it? And the truth be told, nothing. There's no indication that living with a torn meniscus has any negative impact on the patient's joint, unless, of course, it's the extenuating circumstance where it's a locked knee or something like that. But by and large, meniscal tears are just as likely to be degenerative, and they do not seem to adversely affect the long-term survival of the joint. And more importantly, if you operate on them early, what you find out is a lot of those patients then progress to a potentially more accelerated course of arthritis. So there's not a lot of advantage to try and aggressively get MRIs unless you're trying to operate on everybody that comes in the door. And again, it's a bit of a style point. All surgeons look at surgery differently, but at the end of the day, I can tell you in our practice, there's certainly been a bit more of a swing of the pendulum back to the middle of the road, and realizing that most patients with meniscal tears can avoid surgery, and there's not an advantage until you really filter all those patients out and you get down to the very end, and you're like, I've done everything I could possibly do. Am I a candidate? And that's where, sometimes we end up talking to patients. But short of that, they would have done all of these things, whether it's over-the-counter medications or an alternative prescription medication like an anti-inflammatory that's not over-the-counter, or injections. And, people hear about injections. And a word on that is the injections are steroids versus what everybody used to call rooster shots, and now they call lubricating shots, which are actually hyaluronic acid injections. And then people that have done their homework will come in and say, I want that PRP. Yeah. So something that's that you're injecting it to my joint, or if they're really looked around, they'll say, I want stem cells. Both of those are still, sort of fall into what people would consider the investigational category, and not ready for prime time for a lot of reasons, least of all which people are being charged a lot of money to do them. And the benefits, I think PRP probably will make its way into mainstream. I'm surprised that there's not more of a clamoring for that, because there have been any number of studies that have suggested that it has value. But what's interesting is the perception when somebody says stem cells is like, I'm going to have a new joint. They're going to inject magic into my joint, and it's going to miraculously create a new joint, just the same as a salamander loses a limb and it gets a new limb. And it's like, it doesn't quite work that way. And even the people that are doing the basic science research, at least that I've seen, and you listen to them talk, is that they're not really stem cells. And the goal is, once again, to modify the joint environment, lessen the inflammation, which translates into less pain. So at the end of the day, we're trying to treat the symptoms. And some of the PRP in particular may give you slightly longer duration of treatment, but not like a year versus 3 months or 2 years versus 6 months. So you have to sort of put all that into perspective, which is part of our job. So I often Ann, who helped me to put these slides together, or Amy, I said, what are those? And they're like, well, didn't you talk about this idea of fire with flames and then the hot coals? And I'm like, yeah, I did. I'm always looking for some ways to convey to patients what it is, why arthritis works, or hurts. Most of us would say, we'll all see patients with a bad set of x-rays, and like, 2 weeks ago I was fine. Now I'm not. And you're looking at the x-rays, and you're like, those are not normal x-rays, not even close. Pretty much bone on bone. And people say, well, how does this happen? And so I've come up with this idea. There is this magic line, sort of like the blue line on the floor. And there's a magic line where everything below that is inflammation in the joint, which is technically arthritis, but it's inflammation in the joint that's subclinical. Meaning we don't really notice it. It doesn't rise to the level that we notice it, but it is there in the background. And so that would be the person with the hot coals. And it doesn't take too much for any of us that have sort of tried to build a fire. Once you get a good fire with lots of coals there, you just poke the coals and poof, all of a sudden the flames appear. And the flames would be, sort of your clinical symptoms. So for some of us, we live where the coals are, and it doesn't take a whole lot to sort of stir up the inflammation in the joint, and it does take a bit to try and get it to quiet down. Ultimately, most of the injections and everything that we talk about really have to do with quieting down the inflammation in the joint, and if the inflammation drops down, since that translates into pain, it's a happy joint. And so that's the idea. And ultimately, you'd view cortisone or any of the other medical treatments as, the ultimate goal would be maybe a third slide to the left, or it would just be some logs sitting on the in your fireplace, ready to be ignited at some point. But you can poke those, and no flame's going to pop up at any point. So that's sort of the the background of that slide. So at the end of the day, when all else fails, is surgery a viable option? And the answer is it is. If the patients understand what they're getting into, if they appreciate what their role is in the process of getting better, what our role is, but it is certainly a viable option. And if you really look at it, Medicare, loves to tell the story of their joint replacement program. Why? Because it's a huge success. If you think about it, if anybody you know or any of you have had joint replacements, I mean, it takes somebody that would get up each day and wonder whether or not I have to consult my knee or hip to be able to go to the grocery store or not. And then all of a sudden, by and large, 90+% of the time, people are able to get up and not ask themselves that question. They can simply say, I want to go to the store, I want to go out to lunch, I want to do whatever it is I want to do, and my hip or knee has nothing to do with my decision making. And that's really what the ultimate goal is of surgery. And fortunately, it's a pretty good operation for on most occasions. Arthroscopy, very limited role in managing arthritis symptoms. The so-called cleanup procedure that people used to talk about, my doctor took out my torn cartilage and he cleaned up the arthritis. Like, can't really clean up the arthritis. My PA often used this, you say, it's not like barnacles on a boat. It's not like you can, get the barnacles off and the boat looks normal. It's more like, as I say, a road in Pittsburgh after a bad winter, and you're looking around, you're like, that is not going to be a good road this time next year. So you can sweep the cinders away, you can do a little bit of patchwork, but it's not, it's ultimately not, going to work. So joint replacement's a big deal. You got to have a long period of symptoms. You've got to have pain that's pretty much interfering with everything you want to that you want to do, and it has to be around for a long period of time. You don't just jump into hip or knee replacement because somebody says, well, I hurt for a few weeks and I'm sick and tired of it, and you just showed me the x-rays and it says I have bone on bone. I just want to get it fixed. I want to get it fixed. And when people say that, if you think about it, if you step away from the I want to get it fixed statement and ask yourself, what does that mean? Well, the one thing that it means is that they have more faith in us than we have in us, meaning their faith is that they're going to be better and that they're not going to run into a complication and that the outcome is going to meet their expectations on every occasion. And while at no point along the decision-making process can we ever guarantee that you can't have a complication, to me, and my wife would say, well, I'm sort of a half, I'm looking at the glass and I'm a half empty guy instead of a half full guy, is that I'm always looking at what can go on the, can happen on the negative side, because I can be the worst surgeon in the world. And if I somehow do a good job on you and you sing my praises, like everybody's happy. But ultimately, to me, the ultimate test of a relationship between doctor and patient is, God forbid something doesn't go right, did that physician prepare you for that potential possibility? And more importantly, do you have faith in them that they're going to be able to take care of it? Okay, and it's really important. And that doesn't occur with a 30-second conversation and sign me up. It's a process, and it's a relationship that you build over time. And if there's anything that I would say is really, really important in terms of as a surgeon talking to their patients, is valuing that relationship. And it's not just a surgeon; it's the doctor-patient relationship in general. And for any of us, and we've all been patients, you never feel more vulnerable than when you're sitting in the patient's seat. And so it's really important that person that's across the way, across the table or on the other side of the room or whatever it is, has taken enough time to engage you and to give you the sense that they're right for you and that you're right for them. So this is when people end up choosing surgery. It's a popular operation. There are truly millions of these operations done across the world, certainly more than a million in the United States. It really does have a high rate of success. I mean, you truly are looking at 10-year success rates of up to 95% in terms of survivorship of the implants, not the patient, in terms of patients being dramatically improved. Notice I don't say pain 100% gone, because there are a subset of patients that's like, I like my knee, I like it. I just isn't exactly what I thought it was going to be. And in some studies, that's, up to 30%. It's real. And part of it is just, again, framing what it is that we have to offer you. The person that says that I want to be able to ski, chances are you're not going to make them nearly as happy as somebody that says I can barely get out of bed and walk to the bathroom and I stop driving because my knee hurts too much. Who do you think is going to be happier with a significant improvement in their pain? So it's, again, putting the right treatment in front of the right patient. But it's the quality of life change for patients. That's really what you're looking for. I mean, it's real. And for anybody that's had joint replacements that know where they started and know where they've ended up, they truly appreciate the sacrifice they made to go through the operation. The work that they put into it is ultimately sort of just is, they're thrilled with the outcome. So I already said that. Jumped ahead. Questions? I'm out of sync sometimes with my slides. Yes. Sure. Okay. There is no right answer to your, so I'm going to give you an answer. Bear in mind, my answer is part philosophy and part an appreciation of sort of healthcare and where we are. If there's only a finite amount of resources in the world, the question is how to, in any circumstance, how do you use those resources appropriately? For the person that's hurting after a back injury, we'll assume that these are not back injuries, but for the person that's hurting, I just want to know what the problem is. I know there's an MRI out there. I want it. I pay for my insurance. I deserve that. And that's sort of what we encounter from some individuals when they come in. And so behind all that, the important thing is for people to recognize is our job is how do we use those resources appropriately, in the sense that, yes, you can get an MRI scan on a young, healthy 25-year-old that has an athletic injury. The question is, why is it that you want the MRI scan? So for somebody that has a minor twisting injury to their knee, and you'd say, well, what from our standpoint is sort of the dividing line for why somebody gets an MRI? And one is, do they have any swelling in their joint? So if they have x-rays that are normal and they've got a huge effusion, which is a fancy name for a lot of fluid in the joint, and they had a twisting injury and they heard it go pop when they were on the soccer field, chances are, without an MRI scan, doesn't matter, 60% of the time that person has an ACL tear. It's just a classic description. The fluid in the joint, tells you that something's happened. So it's what you see that drives that process. And so a lot of the time is that we get hold more sway when we order the MRI than the PCP. Not because we're smarter, it's just that in theory, we're going to be a little more, precise with our decision making. And so if we see somebody ticks all those boxes, they'll get an MRI scan promptly on every occasion. But for the casual person that has, a twisting injury and no effusion, and they're getting better, the question is, why do they get the MRI? Why do they need it? Bear in mind what I told you, 30% of the time, that person's going to have a meniscal tear. And the question is, now all of a sudden, it's like something in the corner that you're not supposed to look at, but you can't take your eye off of it. I have a meniscus tear. Ben Roethlisberger had a meniscus tear. He had surgery. I must need surgery. I'm going to have an operation. And it's like, so you don't know how to interpret the information you get. And it can be as helpful as it is misleading along the way. And so there's a lot that goes into that decision-making process. And people like nowadays to say, oh, it's the insurance company. That's the classic. Like, oh, why? Because they're just the insurance company. They're not a person. They're not just, they're them. And they're the mean person that's holding back on my care. But by and large, every one of the parameters that's put in place to decision-making for who gets an MRI, who doesn't early on, are all created by physicians, and more importantly, they actually are created for good reason. There's no indication for, if you do an MRI and everybody that has an acute back injury, probably 75% of them are going to be better before they ever get the MRI. and then somebody else is going to be waiting in line who maybe needed it. So ask good questions. Usually what I tell patients is the first visit, unless there's something compelling, you don't get the test, but I usually want them to leave with the idea, if this isn't getting better the way you think, then you come back for a second visit. That second visit is another data point. It's another opportunity to examine them and to realize, so they're not going to get better quickly, and you make a stronger case. So when you're injured, you just want an answer. But there is a process behind it, and it's more complicated. Yes. Um, I assume there's so from our standpoint, again, I always tell them we're just the orthopods, so we're not the smart medical doctors. But so by and large, there's lots of reasons why people aren't supposed to take anti-inflammatories. There's a whole host of side effects that can go along with them. But if you are not sort of a person who can tolerate ibuprofen, so the NSAIDs and all the long laundry list, then you're down to a fairly short list. I don't know anything other than steroids or something like that might be viewed as a anti-inflammatory option in that setting. But steroids have a lot of side effects, so there's not a good option there. There are not that I'm aware of, other than agents that are specifically targeted to inflammatory arthritis, that are out there that are going to provide you the anti-inflammatory benefit that you're looking for, that without taking an anti-inflammatory. There were some studies years ago, and I've heard this repeated more recently, that say that glucosamine and some of the health food supplements and turmeric and stuff may have some anti-inflammatory benefits behind the scenes there. If you think, sort of that people don't appreciate but aren't classic, NSAID medications. So I don't know. I don't have a good answer. Your PCP would probably have a better answer than I've just given you. Your PCP might have a better answer than I do because they may understand the interactions with some of your other medical conditions. But well, they understand, but they don't have a better answer, which is, yeah. So, but well, it depends on what again, behind the scene, the question is what the problem is and what other options. But yeah. Yeah, and 9 of them probably all belong under one category. They're all more or less. And, yeah. They're noise. So to me, that's noise in the background that you should ignore. That's what I try and tell patients. And you're like, that is the most non-medical answer that I wanted to hear. So step away. So what does it get? What's a popliteal cyst, Baker cyst, whatever, whatever you want to call them. So our joint produces fluid. Okay. And it normally produces fluid all the time, but there's a balance, just the same as your eyes produce fluid. They're tears. When you overproduce them, they run down your face, but they're easily wiped away because you take a Kleenex or something like that and you move them away. In your knee joint, there's nowhere for them to go. So when things are out of balance, your body there's a defect in the joint capsule for patients that overproduce joint fluid, and some of that fluid escapes out, and that's what people call a Baker cyst or a popliteal cyst. Okay, they can be uncomfortable. I have one in my wrist, and sometimes they're sore, but they're due to an overproduction of fluid. And the question is, why are you overproducing fluid? And that's the answer you need to look for, not stick a needle in somebody's knee and aspirate the cyst. No, it's usually arthritis. It's inflammation in the joint overproduces the fluid, just the same as in your eyes. If you have dirt in your eyes or you have pollen in your eyes or whatever it is, it's an irritant and your body produces more fluid. The joint's no different. When the inflammation's up, it produces a lot of extra fluid. And people come in and like, I have a Baker cyst. Okay. So, and then you go through this long explanation and you explain we're going to give you a shot of cortisone in your knee. It's like, the Baker cyst is back here. Why give me a shot up there? And then you try and go through this explanation. Sorry, not across the blue line. But you try and get this explanation that gives them some sense as to why it is that you're ignoring something that they thought was really important. it's part of, it's like, you should look at it more of a spur on the joint than a problem that you have to solve. Because if you get your pain to go away, I guarantee you won't be paying attention to whether you have this slightly smaller half-size golf ball in the back of your knee, because you're feeling better. Yeah, but you may have a ganglion here or somewhere. There are other, okay. Okay. Anyway, I'm now officially already gummed up the works here. But
No, that's okay. No, that's okay. Yes, please give a round of applause.
Thank you.
Thank you, sir. We'll trade. You get to take that.
Liquor?
Yeah.
Oh, good.
That's how I roll. All right. Thank you again. He's going to be in the back for a little while. If you have another question, didn't get answered, and I'm going to switch off and get our next slides up.